Good afternoon, everybody. Coming to you live from Houston, Texas, deep in the heart of Texas. I'm Dr. Randall Wolf. This is DeBakey CV Live. We're coming to you from specifically the studios at Methodist Hospital in the Texas Medical Center in Houston, Texas. CV Live, DeBakey CV Live. The name DeBakey has been around Houston for a long time. Dr. DeBakey started this heart surgery program many years ago. And the CV Live was added by Dr. Lumsden, who's the current director of DeBakey, to get the word out about different programs and different diseases. And this is no exception. The first Tuesday of each month at 5 p.m. Central Time is when we talk about arrhythmia surgery and most commonly lone AFib, and that's our topic today as well. This is a very special hour, and it means a lot to me because I'll be joined here by Sandra Schremeyer, who goes by Sandy. She is the administrator for the Facebook site Wolf Mini Maze, and also it's Live AFib Free. And she reached a milestone here recently with 2K followers on that site. Sandy has pretty much single-handedly grown that site. No one knows more about the frequently asked questions about AFib than Sandy, so it's a pleasure to have her on here. And the lovely Sandy will be joining us for the rest of the hour. She has questions that are frequently asked questions that she'll bring up, but also you as the audience can ask any question you like. You have a couple different ways to reach us, and my recommendation is reach us sooner instead of later in the hour, so we'll have time to get to your question. One is to text DeBakey at 37607. So you go to 37607 on text, and then in the box type in DeBakey. The other, as you can see on the screen, is go to pollev.com. That's if you're on your computer, or I guess you can do it from your phone as well. And you enter DeBakey and then respond to the activity. And in this manner, you can ask any question that you like during this hour, and Sandy and I will do our best to get to your question. The treatment of lone AFib is a pretty hot topic, and it has been for some time. And I think it's gotten more hot for several reasons. One is you see advertisements on TV for treatment of AFib, most commonly newer blood thinners. It's a very big business, multi-billion-dollar business. People wear watches that show them their heart rate 24 hours a day. So they have smart watches. We have smartphones. We have Cardia that we can get for $89 on Amazon, and it's delivered within 24 hours, where you can put your fingers on a pad and see your EKG, and you can email it to someone. There are new techniques for treating AFib, including catheter ablation and newer ways to close the appendage of the heart. And by the way, with a little bit aside to that, the Wolf Mini Maze site, wolfminimaze.com, has been completely redone. Completely. It's really nice now. It makes a lot of sense. It's easy to navigate. And if you want to talk about the left atrial appendage, you can go to the wolfminimaze.com site and navigate from there to Dr. Miranda's site, which is clinical anatomist, and you can get to that site right from the Wolf Mini Maze. It'll show you the appendage, it'll show you the interior of the appendage, why it's a problem with AFib and strokes. So now you can navigate through the website and get to all these other places. And I have to thank Dr. Miranda for spearheading that effort of completely redoing the Wolf Mini Maze website. So if you haven't seen it for a while, or if you've never seen it, please go to wolfminimaze.com and and look at it and comment. We'd love to hear your comments. But it's a much smarter site now. Now that's separate from the Facebook site. The Facebook site is Wolf Mini Maze, Live AFib Free. It's a private site, but generally all you have to do is say you're interested in AFib, and Sandy, out of the goodness of her heart, will let you in. There are a lot of people on there. There's a lot of good information on there. But like everything on the internet, there's a lot of information. What you have to do as someone who's interested in AFib, most of you are suffering from AFib, you have to take that information and find the knowledge. The knowledge is not always staring in the face. You have to find it. And sometimes even harder than that is to find the wisdom. Where's the wisdom on the internet? Well, it's not marked with an asterisk. You have to find it. And Sandy's very good at helping people navigate these things to try to find the knowledge and the wisdom and ferret that out from the vast amount of information that's there. Sandy was in the medical business, registered nurse, and has many years of working with patients, so she understands patients. And she was kind enough to join us today for this, so official welcome. Sandy, thanks for coming on for this particular Tuesday version, frequently asked questions on AFib.
Glad to be here. Thank you.
We have some questions coming in already. We're going to get to some of those. And we also want to get to some of the questions that you hear frequently. And also congratulations for getting to 2K on the site. It's probably a dubious honor because it just means you get more calls. But I think what we ought to start out, just so people know, if you don't mind, maybe give a brief synopsis of why you got interested in AFib, because it's really, I know, a personal story, but you don't mind letting people know a little bit of how you got going on this, do you?
Not at all. Not at all.
Well, the floor is yours.
I had three failed ablations, and I was then told that the only other option for me was to have an AV node ablation and a pacemaker, and I absolutely refused that. I did my own research. I found you, and you said the 5 words that made my world better again. You said, Sandy, I can help you. And I had my mini maze July 11th, 2018, so it's over 5 years now. I take no medications. I do not have AFib. I take no blood thinner, and I am not pacemaker dependent. I just was flabbergasted that people weren't allowed or weren't told about this option. And, you know, it just made me want to get the word out. And here we are.
Yeah, and that was a big mistake when you said you'd help, because how many people you think were on that Facebook site when you took it over?
9.
9.
9 people. 9 people.
Yeah, it's amazing, truly amazing. Yeah. And a little bit about your work history.
I've been an RN for years. I recently retired.
You worked in the hospital for a while, didn't you?
I did.
Yeah.
All the time. Yeah,
okay.
I've always worked in a hospital. Finished up my career in labor delivery, loved it. Would do it again in a heartbeat. But time to leave it to the younger nurses.
You mentioned that you were told your only option was a AV node ablation and a pacemaker, and I think some patients don't understand that that does not cure the AFib.
It does not, and I knew that. Cardiology wasn't my specialty, but I learned really fast when I got AFib, and I definitely knew that pacemakers were meant to treat very slow heart rates or very long pauses, both of which can be very dangerous and life-threatening. And I knew that that wasn't going to help my AFib. I knew there had to be a better way. I just knew it was going to be up to me to find it.
Were you ever told that you'd be on blood thinners for the rest of your life?
Oh, yeah. I was told that, this is, just get used to taking a blood thinner and get used to probably having AFib the rest of your life. And that's not my personality.
I'd like to take one question that's on the board. Again, for people out there listening, we'll put it up on the screen again here. If you're on your phone, you can go to text 37607 and then in the little box put DeBakey, and you can text your question to us. We'll do our best to answer it. If you're on your computer, you can go to pollev.com, enter DeBakey, and then respond to the activity. And I ask you to get your questions in early in the hour so that we have time to answer them. It's difficult to answer them when it's at the end of the hour. Here's a question that came up. Is hybrid ablation effective for vagal AFib? So first of all, I guess what we need to understand is what is a hybrid ablation as it's being practiced today, at least in the United States, and is that the same or is that different from the mini maze or open maze? And then we can answer the question, is it effective for vagal AFib? In my opinion, and if you go back to the webcast last month, we spent 50 minutes talking about lone AFib, and the hypothesis that I have had and others have had that it's strictly a nerve problem. It's a nerve problem, it's an autonomic nerve problem, and the nerves of the heart are on the outside. They're not on the inside. So a procedure that attacks the outside of the heart and specifically isolates these little nerves that are causing the problem should be very effective. A procedure that goes from the inside of the heart, where it's pure muscle, may not be as effective because the nerves are on the outside of the heart, not the inside. So, a mini maze, a Cox maze, all are procedures that do affect the nerves on the outside of the heart and are very effective. Catheter ablation goes from the inside of the heart, so it's very difficult technically to get the nerves on the outside of the heart from the inside. So first of all, a hybrid ablation definitely includes as part of it the catheter ablation. So you as a patient will be dependent on the catheter ablation doing a good job. But that's difficult. So right there you're kind of behind the eight ball. You're depending on a technology that goes from the inside of the heart that at best in patients who have persistent AFib has a 1-year AFib free rate of less than 50% at best. The other part of the hybrid is to go underneath the breastbone. The surgeon goes underneath the breastbone, opens the heart sac, and burns the back of the heart. So the good news is it is on the outside of the heart and can affect some of the nerves, but it doesn't affect all the nerves. And if you want to get a good AFib procedure, you have to get all the nerves. So my concern with the hybrid procedure is, number one, it still depends on a catheter ablation to do part of the work, which doesn't work that great. It's being used on people that are out of rhythm all the time, so these are tough cases. And secondly, it depends on the surgeon doing part of the nerves, but not all of them, and not measuring any of the nerves, and simply carpet bombing the back of the outside of the heart. So, as you can imagine, based on those shortcomings, I'm not a big believer in it. I also see patients every month that have had the hybrid procedure, it fails, and then they come to me for a mini maze. It's very difficult to do a mini maze after a hybrid procedure has been performed. It's very tricky. So it matters where you go first, and hybrid is kind of a dead end, and I don't think it's a really good one, but that's my personal opinion. Is it effective for vagal AFib? It increases the chances of staying in rhythm about 10%, but you're talking about the catheter at 30%, so you go up to 40 or 50%, which is still not very good. So that's a long answer to that question. The questions are starting to come in, so that's good. But I want to switch now to Sandy. We'll go back and forth. Sandy, I'll let you take a question, something that you see often as an administrator for the live AFib-free website, Facebook site.
Mm-hmm. A lot of people will ask me, does the Wolf Mini Maze help with PACs and PVCs, and how about flutter?
Mm-hmm. And that's a great question, and we better break it up a little bit. For PACs, it's not a procedure for PACs. If they decrease after the mini maze, that's great. I'll take credit for it, but it's not the stated treatment for PACs. For PVCs come from the lower chambers of the heart. So unless the AFib is triggering the PVCs, it won't help a lot. Mini maze won't help a lot. Flutter is the most interesting one. So the short answer is yes, depending on what type of flutter it is. If it's left atrial flutter, it's a big yes. And this is a very common complication in patients who've had catheter ablation. Left atrial flutter is so common that there are whole conferences on what to do about it. And it turns out that the mini maze will stop that, because what we found is when we check the veins on the outside after catheter ablations, the outside is still transmitting the electricity through the nerves. And that can lead to this flutter, this left atrial or atypical flutter. And the mini maze will stop that. If it's typical flutter, which is right-sided flutter, an ablation is a better procedure.
I struggled with flutter for a full year, remember? And I knew I would. I had, after the 3 ablations, I had to be cardioverted after each one of my ablations for flutter. So I knew I was going to be probably inundated with flutter after my Wolf Mini Maze, and I was, but I struggled through. And I actually did talk with Dr. Fayed, thinking I was going to need a flutter ablation, and it just stopped, and I've never had it since. So I was either a slow healer or for whatever reason it stopped.
It sort of burned itself out, but it took a long time, I know.
Close to a year.
Yeah. So the short answer is left-sided aflutter, yes. Pure right-sided typical flutter, better with a catheter ablation. Now I'll switch over to what we have here on the board, Sandy. How long after a Wolf Mini Maze can you go back swimming in a home pool? Well, in general, it takes a couple weeks for incisions, the skin to heal over well. So I tell people a couple weeks is fine. The incisions should be healed unless you have some unusual incision. So the short answer is about 2 weeks. Another question is, do you have, let's see. They're shortening it up a little bit. Do you have to map the heart to locate the nerve locations before the Wolf Mini Maze? Well, yes and no. What I figured out were the areas where these nerves are most prominent, and I test those with a special pen. We give a tiny bit of electricity through the pen to the surface of the heart. It's very specific. The pen only is active in about a centimeter of area, so very small. And it's such a small amount of energy that you wouldn't even feel it on your on your finger. And I've determined there are 9 areas on the right and about 9 areas on the left near the right-sided pulmonary veins, left-sided pulmonary veins, where the nerves are very active. These can also be seen as 4 bigger areas on the back of the heart. So I kind of know where these are, and those are the areas I test. And if any of those areas are active, then I treat those areas, and then I test them again to document that they're not active anymore. So that's the general way that it's done. That's done during the procedure, during the part of the mini maze before we do any of the clamping or close the appendage. So we do some mapping, but it's during the procedure. Back to you, Sandy.
I get a lot of people wondering why their heart rate's higher for so long after the mini maze. I know mine hung in the mid-90s for probably 9 months or so before slowly coming back to normal.
Well, the answer is that it's based on the autonomic nervous system. These nerves have both sympathetic and parasympathetic ganglion, and 80% of them are mixed. So the easy way to think about it is the parasympathetic system slows your heart. So if you were to do a yoga session and really get deep into it and become mesmerized, that's the parasympathetic system, and your heart would slow down. The opposite, and we've used this before, is watching a scary movie, and then your heart rate would go up, and that's the sympathetic system. Or running, or being scared, or looking over the edge of a tall building. So the balance is not the same in everybody. So by decreasing the nervous input around just the left atrium, and by the way, these nerves are all over the heart. We're attacking the ones that are around the left atrium. By decreasing the ganglionic plexi, which are the sympathetic and parasympathetic nerves, we may slow some, we may raise some. The overall balance in your situation left you with more of the sympathetic, I think, than the parasympathetic, so your heart rate was a little higher for a while. In some people, it's the opposite, Sandy. Their heart rate's really low for a while, 40, 50, and then slowly it comes up. I think if you have a change in heart rate, whether it's higher or lower, that's a good thing. That means we got to the ganglionic plexi, the vagal part. Now the vagal, strict vagal, if you take out the vagal, your heart rate should be higher, because the vagal is the parasympathetic, the slower. It slows your heart rate. So the vagal AFib, you usually think of, if you take that out, your heart rate will be higher. Let me see. What is the risk of having a Wolf mini maze? Well, it's a cardiac surgical procedure, and there's every complication under the sun. We've never lost anybody in the operating room, but the worst complication of any surgery is a death. So that's always a risk, but it's very, very, very low. There's a chance of having a blood clot in the leg. That can happen with any surgery, any general surgical procedure, orthopedic procedure, spine procedure. You can get a blood clot in the leg. You can get pneumonia. That's another complication of pretty much any surgery. There are some complications that thankfully we've avoided, but they have been reported with doing this sort of procedure. One is cutting the phrenic nerve, and that would paralyze one of the diaphragms, and the patient would be symptomatic after the procedure with shortness of breath. We've never done that. We've never had that. Another is massive bleeding that can't be controlled. I think those are some of the main ones. Fortunately, we generally don't have that. We're not 100%, but we don't even usually send patients to the ICU. It's a heart surgery procedure, but usually they go to the recovery room now, and then they go to the floor. The chance of a stroke is 100 times less than a catheter ablation. In 3,000 cases, I've had 3 strokes. It's not 0, but it's 100 times less than a catheter ablation. Bleeding is over 100 times less compared to a catheter ablation. Back to you, Sandy.
I get a lot of questions about clamping the left atrial appendage, that there's got to be some side effect to doing that. And somebody actually said that they had heard that clamping the left atrial appendage would cause increased pressure in the left atrium.
Mm-hmm. Yeah, good question. Of course, this goes back 40, 50 years. There were some articles that suggested that the left atrial appendage was kind of a pop-off valve for the left atrium, and that if pressure got high in the left atrium, it could be relieved by the area in the appendage. This is a discussion I had with Mark Lemaire in Europe 20 years ago, because Mark was hesitant to close the appendage. Why would you close the appendage? Well, one, it pretty much eliminates AFib strokes, and you don't have to take blood thinners anymore. Number two, the appendage can be part of the reentrant circuit of AFib. So if you close it, you electrically isolate it, and it is then no longer a part of the AFib focus. And by the way, the Watchman device, which is another thing that's been promoted on lots of different advertisements, I think TV included, it does not electrically isolate the appendage. And I've had instances where the patients have come for a Wolf mini maze, they've already had a Watchman in place, and I take my little probe and I put it on the appendage that's clotted off, essentially, but it still has electricity going through it. So it's proof that the Watchman does not electrically isolate the appendage. So we have some really compelling reasons to close the appendage. Decrease the risk of stroke, get off blood thinners, decrease the AFib focus. And lastly, what's been shown in the last few years, also decrease blood pressure in patients who are hypertensive. It also decreases your blood pressure by closing the appendage. So that's on the plus side. On the minus side was this little thing hanging around that you needed the appendage as part of the system of the left atrium. So I give Mark Lemaire credit. He put catheters in the left atrium during the procedure and then closed the appendage to see if it increased the pressure in the left atrium. Because that was the hypothesis. You would create higher pressures in the left atrium if you close the appendage. Guess what? It didn't matter a bit. So he debunked it. It's no longer out there really to be true. The appendage used to be called the appendix, and as we know, getting rid of your appendix is not a bad thing. And getting rid of the left atrial appendage is not a bad thing. So if you want to go back 40 years and look at a paper, yes, you could argue that it might be important, but it's been proven that that's not true. So there are a lot of advantages, no disadvantages. Can you perform mini maze after mitral valve open heart surgery? Sent with loud effect. The short answer is no. I lament the fact that some people go to open heart surgery, like a mitral surgery. They have known AFib and nothing's done about their AFib during the mitral surgery. And then unfortunately they call us a year or two later and want to know what we can do. And when I ask them if they had AFib before and they say yes, I'm so disappointed and so sad, because really that should be addressed at the time of open heart surgery. It is almost impossible to try to do a mini maze after mitral valve surgery. There's a lot of scar in the places where we need to go, and it's really, in my own experience, not safe. We haven't had trouble doing it, but it's very difficult, and I don't think it's safe. So the short answer is no. Sandy.
A lot of people are curious about the link, and I know that you like to use them, but they want to know if you could please explain the monitoring procedure for the link. What is recorded and reported, and when are you notified when there's an issue, and how can my local cardiologist get the data?
Well, let's back up a little bit. I think a lot of people are aware of the implantable loop monitors, but you may not be. An implantable loop monitor picks up an EKG continuously, and once every 24 hours it sends a sample ECG to the practitioner. The current ones go through your phone. So the link device is about that long, and it's not as fat as my ink pen, and it goes under the skin over about the fourth intercostal space to the left of the breastbone. I put them in all the time. I put them in today. I do it in the office. You numb up a little area on the skin, and with a syringe, a special syringe, shoot it under the skin. So it's not in the heart, it's not in the chest cavity, it's under the skin. It is essentially what we call a 2-lead EKG. So it gives us a little EKG, and it has an algorithm. So if it picks up something that's extremely abnormal, it will send an alert to us, the clinician. Now, does it send an alert every time the patient goes out of rhythm into AFib? No, it does not, because we would be inundated with those. We do these on patients before they have the mini maze to see what their AFib burden is. we've set parameters on there that are based more on the absolute rate versus the rhythm, unless it's a dangerous rhythm. If it picks up ventricular tachycardia, we're going to be alerted immediately. If it picks up AFib or aflutter, we won't be alerted immediately unless the rate's too high or too low. So if the rate is very high with aflutter, which it can be, 150 beats a minute, we will be alerted right away to that. If the heart rate is very low, if it's 40 or 50, below 50, we'll be alerted right away. If there's a pause, if there's more than a 3-second pause between heartbeats, we'll be alerted immediately. And this, when I say immediately, it still goes through the internet, and it's in the form of an email. So unless we're looking at the email right that second, we're not going to see it. We'll see it the next time we look at the email. And Kimberly, our RN, monitors that. If it's in the middle of the night, we probably won't see it till the next morning. So the short answer is, it doesn't alert us for everything. It would be too much. It's our job to check it every month and see what the AFib burden is. Extremely low rate, extremely high rate, extremely dangerous rhythm, yes. Is that, what else do you have there?
Okay, I'm sorry, go ahead. How can someone's local cardiologist get the data?
Okay, thank you. Yeah, great question. Kimberly's been very good in supplying that to any physician who wants that information on a monthly basis. So if a patient requests that the clinician get a monthly report, we have been doing that. Is that anything else there, or was that it?
Nope, that was it.
Okay.
That was it.
And I will go back to the board. What is your opinion on the pulse field ablation? Pulse field ablation, also affectionately known as PFA, is a newer way to do catheter ablation, but it can also be used for the surgeon as well. And it's different in that it's very fast. Instead of an alternating current, it's a direct current. And the way it works, it creates a very short, very powerful pulse. And what this does is open pores in the cell, and water rushes into the cell, and the cells burst. So if a cell is in the area where the pulse has been applied, the cell will burst and you'll get cell death. So that's pulse field ablation. The electrophysiologists like it because it's much faster than the traditional catheter ablation. So they can take a catheter ablation that may usually take 4 hours to do and do it in 1 hour. That's great. Has it lived up to its promise? The promise was not that it would be faster. The promise is that it would be superior in results. So more people would be AFib free. If you look at our own institution here, and you look what was published 2 years ago with persistent AFib, the 1-year AFib free rate was 36%, and with ablation of the ligament Marshall, it went up to 46%, which is still not very good. So the hope is that a new technology would increase the AFib free rate with catheter ablation. Well, guess what? The midterm results were no different than radiofrequency. And they touted this fact. They said, we really like pulse field ablation because it's safer, because it doesn't hurt the nerves. Well, now wait a minute. I opened most of my presentations on AFib by saying lone AFib. It's a nerve issue. So now we're touting a technology that's guaranteed not to injure the nerves. So I didn't expect the midterm results of pulse field ablation to be any better than radiofrequency, because I think they're missing the point. And so far it hasn't been. Let me go do another one, Sandy. Do you have to check inside the appendage for blood clots before you close it? Yes, we do. And the way we do that, we usually do a CT scan a couple days before the procedure, very accurate way to see if there are any blood clots anywhere in the heart, including the appendage. But in addition to that, After the patient's asleep, we usually put a transesophageal echo probe down into the esophagus to look at the appendage and document there's no blood clot in the appendage before we close it. Very rare to see one, but we do it. There was some stuff on the Facebook about a patient who had mini-maze a year ago, and unfortunately they had a hole in their stomach which had nothing to do with the mini-maze. It had to do with that transesophageal echo probe being put in there to make sure there weren't any blood clots. That's done by the anesthesiology staff. Fortunately, we made the diagnosis afterwards and treated it, and the patient survived and is alive today. But what we did after that is I asked the anesthesiologist to not put the probe all the way down into the stomach. Just keep it in the esophagus, because usually we can get a good enough picture of the appendage without going into the stomach. And my goal is to eliminate that rare, very rare, but real chance of having some complication from doing the echo. So that was our solution to that. But yes, we do. Here's a comment, but it's not a question. Sandy was extremely helpful in deciding to proceed with mini-maze, I guess for helping me decide to proceed with mini-maze. So there's a big star for you, Sandy, but I think you get a lot of those. You want to, I'll take back to you.
Okay. What are the chances of esophageal damage with the mini-maze?
Yeah, that comes up a lot, I think because that's a real danger with the catheter ablation.
Catheter ablation.
The catheter ablation, in short, generally relies on a radiofrequency burn on the inside of the heart, but the way it's done is you have to have a grounding pad somewhere on your body, on your leg or your rear end or your back. So the electricity goes through that probe that's touching your heart and takes the path of least resistance down to that grounding pad that's on the outside of your body. By the way, with the Wolf mini-maze, we don't do that. The electricity only goes from this side of the clamp to this side of the clamp. So it's extremely safe. But with RF ablation, it goes from the heart to the outside of your body. And if it takes the path of least resistance through the esophagus, it can burn the esophagus, create a hole, and that's a very morbid complication. In other words, the death rate from that is over 60%. Now, it's claimed it only happens about 1 or 2% of the time, but with a death rate of 60% or higher, it's still a big deal. It does not happen with the mini-maze because the electricity only goes from one side of the clamp to the other. Okie doke. Oh, well, this is interesting. Is there any research which assessed how often atrial fib occurs, especially in young persons, on a hangover? And if there's such evidence, what's the reason AFib on a hangover? Can it be electrolyte disturbances? Well, I think if Sandy and I figure that question out, we'll probably get the Nobel Prize in medicine. I don't think anybody knows. It could well be an electrolyte disturbance, but we also know in some people that alcohol is a trigger for AFib, and that's pretty well known. And some people dramatically decrease their alcohol intake and they have less AFib. It doesn't usually cure their AFib, but it can decrease the occurrence. So it could be the alcohol, it could be being dehydrated, it could be electrolyte disturbance. However, by the way, there are many patients I've done a mini-maze on who are under 30 years old, and they weren't drinkers. But young people get AFib too, they just don't get it as often as older people. I took care of one patient when he was a medical student and had continuous AFib, and he's been out of AFib now for over 10 years. I've done some patients in high school who had what's called a channelopathy, or a genetic problem in the family that predisposed to AFib. And we've done people, at least 40 or 50 people under the age of 30. It occurs, but it's not as common. Dr. Wolf, I'm almost 2 years post-Wolf mini-maze. would you talk about handoff to my local cardiologist? Well, I think that's great. It's if your cardiologist is understanding of what you had performed and they're supportive, then 2 years is plenty. Now, we're happy to hand over the link information to the cardiologist and even transfer the link data to the cardiologist, and they can even manage that, especially if you're not having any AFib anymore. I think that's fine. Sandy, what's your comments on that?
I'm not really sure. I think that, first of all, I don't think you need an EP anymore. I think a cardiologist is good because you don't have that arrhythmia any longer. You just really need somebody for heart health now. But yeah, transferring it to your, probably is a good idea to have him have all your information.
You know, Sandy's seen all this, and I have too. She's very careful about what she says, but you know, some patients go back to the cardiologist, and the cardiologists don't want to see them anymore. They're not happy that they left the practice and went somewhere else for a procedure they don't do. Other cardiologists are very understanding and supportive, and they will support the patient on their trip to try a different technology and take care of them when they come back. So it's a pretty personal thing, isn't it, Sandy? I mean,
it is. It is.
It's
well, with the EP, they can't do it, and they will tell you, you know, don't do that. It's too invasive. You'll have a horrible recovery, and it's not. It's not. Yeah.
Yeah. So it depends. Does Dr. Wolf have a protege that will take over when he retires? Has Dr. Wolf ever discovered that a patient has been misdiagnosed with AFib? Well, I'll take the second part first. Yes, it's not too uncommon that patients are misdiagnosed, and we try to sort that out. So we take a good history. And if the history raises some red flags, then generally I'll recommend a link, at least a 2-week monitor, and see what the patient's really having, but I prefer the link. And sometimes we find out that although they were given a diagnosis, it could have been in an emergency room somewhere of AFib, they have something else. I've seen patients that had primarily non-sustained V-tach, but they were diagnosed with AFib. So it does happen, and that's part of our job, is to sort that out for you and find out. That's the first question we want to answer. Is this really AFib? If it's typical atrial flutter, you're better off with an ablation. Is it AFib? Is it something from the ventricle? So that's happened. The protege part is more difficult. I have a protege who's in Tokyo, Dr. Otsuka. He calls it the WO procedure, Wolf-Otsuka procedure. He's very good at it. We were over there this year during Cherry Blossom Festival, which was very nice. And I was in the OR with him, and he still does a fantastic job. Unfortunately, he's pretty far away from Houston, Texas, but he's been able to help a lot of people that can't come to Houston, and Sandy's been involved with that as well. There are many people now that you've helped get to Dr. Otsuka, correct?
Right. Well, I get a lot of contacts from people from all over the world because of the YouTubes I've done with you, and it's nice to have that other option for people in that area.
People ask me, why don't you have a lot of other people training? And I think the answer is multifactorial. Number one, most cardiac surgeons are not very interested in arrhythmia surgery. It's not their forte. They're just not very interested in it. Just like not everybody's interested in calculus. Not everybody's interested in organic chemistry. Secondly, most cardiac surgeons do not like to operate while the heart's beating. They're not comfortable operating on a beating heart. And thirdly, if you then say to the surgeon, you also won't be putting your hand inside the body while you do this, then that's just a bridge too far. So they're not real comfortable with arrhythmias, they're not comfortable operating on the beating heart, and they don't want to operate on the heart while it's beating without putting their hands inside the body. And that becomes the bridge too far. So there's several reasons. I am looking for someone who wants to take over for me, and I've been talking to people, but it's hard to find that perfect person that not only answers all those questions I just talked about, but also someone who's passionate about this. Because Sandy and I are both passionate about this. We have the most grateful patients in the world, but it takes a lot of work. But we do it because we're offering hope to people who had no hope. As I've said before, hope is probably halfway to happiness. And if you take someone, as Sandy's done many, many times, and say, you can get off blood thinners. I've done it myself. I'll show you what you need to do. Well, you've given hope to someone who had no hope. And that's a tremendous feeling. Right, Sandy? I think that's one of the motivators for you, isn't it?
It is. And, you know, my people have heard me say this, but I had my EP actually look me straight in the face and say to me, AFib will not kill you. And I looked at him and I said, I'm not afraid of dying. I'm afraid of living like this.
Good point. Good point. So that's one of the reasons we continue to do this. If any of you out there know of someone who's really interested, who's a really hotshot surgeon, please give them my name and I'll be happy to talk to them. And it's going to take about a year to train somebody for this position. What happens if you do find a blood clot from on the CT? And that has happened. First of all, we can't do the mini-maze. We have to postpone it. And we start the patient on Coumadin. Coumadin seems to be a little bit better at breaking up these clots. And then we wait a couple months and do another CT, and usually it's dissolved by then. If it's not, and that's happened too, I had one patient, she is a, what is she? I think she's a yoga instructor out west, and she had been out of rhythm a long time. She came for the mini-maze, and she had a big clot in her left atrium. And I said to her, I don't think all the Coumadin in the world is going to break this up. It's just too big. And in that case, we just went to the open maze and did a Cox 4 maze, and she's doing fine. So in some cases, if we don't think the clot's going to get better, a big clot, then we go to an open procedure. Another patient came here a few months ago for the mini maze. He'd already had a Watchman put in, but when we did the CT scan, he had blood clot on the other side of the Watchman, on the ventricular side, just floating there, flipping around. And same with him, Coumadin, but if it doesn't clear, then an open procedure would be necessary to make that safe for that patient not to have a stroke. Let's see. My wife works for HCA in Nashville. Our insurance is United HCA. I'd like to get the Wolf Mini Maze, but my wife feels the hospital must be an HCA facility to be covered by insurance. Any insights on this or who to talk to at your hospital? Thank you. That's a difficult one. The mini maze is covered by most insurances, but not all. And there are 1,000 different insurance programs out there, and that's not my area of expertise. Generally what people do, frankly, is they change their insurance and they get an insurance that's covered by what we do. Short of that, sometimes it's difficult. Sandy, you probably run into this too. Any words of wisdom?
I get questions all the time on insurances, and of course that's not my thing either, but I will give them the insurance codes and they can call their own insurance and they can give them those codes and they can tell them right there if it's covered or not. But a lot of people have changed. I know there's some issues now with some of the Advantage plans. So, you know, there have been people who have switched to get into a different plan to be able to have the procedure. But
yeah, well, the good news is Medicare has covered the mini maze, and it always has. And we don't even have to call Medicare and get a pre-certification.
Right.
If you have straight traditional Medicare,
Medicare,
that's the best. Regular Medicare is the best.
Yeah.
You can come from anywhere in the country, or even territories like Guam. You can come from Guam and get the mini maze.
Uh,
Question to you. What do you got? Another question there?
Yeah, I get a lot of questions on amiodarone. Amiodarone really has a bad name. People want to know why they have to come off of their flecainide and go on amiodarone prior to the procedure.
Okay, well, the short answer
especially
is,
those with thyroid issues.
yeah. For those of you who don't know, amiodarone is a very effective medication for AFib. It was FDA approved for life-threatening ventricular arrhythmias, lower chambers. AFib is in the upper chamber. But 88% of the use of amiodarone around the world is for AFib. And it works because there's an iodine molecule, or iodine in the center of the molecule, and that's the active part. So about 33% of amiodarone is iodine. And there are some people that have also come up with some treatments that include iodine because it does work. It calms the heart. It does have a lot of side effects, and it's generally used in large doses, and I think that's the problem. So generally what I do is I give patients very low dose amiodarone. I don't load people with a gram. I give them 100 milligrams a day. You have to take the 200 milligram tablet and break it in half. That's how small the dose is. And I've found that in a small dose, over a longer period of time, you still get the same effect without the side effects. But large doses have a lot of side effects. Now, you don't have to stop flecainide, but in my experience, the amiodarone is so much more effective in calming the heart after the mini-maze compared to flecainide. Flecainide tends to not help it at all, even hurt after the mini-maze. And Dr. Otsuka in Tokyo has had the same experience. We've shared our experiences. Low-dose amio just calms the heart, and then you stay on it for about 90 days after the surgery, and you can get off of it. If it's paroxysmal AFib, you don't need it before the surgery, but if it's persistent or continuous AFib, it's very helpful in a low dose. Low dose is the key. It can mess up the thyroid, but the key is low dose. Sandy, any other comments on that?
Well, since you're talking about the iodine content of amiodarone, there was some discussion this week on the site about taking iodine supplements to treat AFib. How do you feel about that?
Well, I don't know much about that. There are some people that say it's effective, but I really don't know. They say that it's effective without the toxicity, but I have not seen that in the scientific literature. So I'm not sure if that's more along the lines of a supplement where we don't know a lot about it. It may be effective. Some supplements are really strong medicine. Don't get me wrong, but sometimes we're not sure. I really don't know. Gosh, we're running out of time, and we didn't get to all the questions, and we didn't even get to all of your questions. So let's see.
I'll save them.
How far in the pulmonary veins can the point of origin of AFib be? Have you ever had a case where you had to ablate a couple of millimeters inside the pulmonary veins? Well, here's the point. The pulmonary veins don't matter. It's not the pulmonary veins. That's what the electrophysiologists target, and they have to isolate the pulmonary veins. I don't touch the pulmonary veins. And our results aren't 5 or 10% better than a catheter ablation. They're 100% better because we target the nerves. That's what you have to do. Stay away from the veins. We don't touch the veins. We're inside the veins, on the heart, where the nerves are, and that's the key. What's the incidence of AFib recurrence, AFib 1, 3, 5 years post-mini-maze? Well, generally speaking, the recurrence is very little. When you get to 1 year and you're AFib free, you're probably pretty good to go, with one caveat. We had some increase in AFib recurrence in patients who got the vaccine or who got COVID. And one patient was 14 years out. 14 years. 2 days after he got COVID, he got AFib. And I had some others that were various years out, but way out. And the second they got the vaccine or COVID, or within 2 days, they went out of rhythm. So this virus does cause some myocarditis, inflammation of the heart muscle. and that's caused some recurrence of AFib, but not a lot. So once you're out a year and you're good, then you're pretty good. I have a bleeding ulcer close to the blood vein on the esophagus. Doctor clipped it, stopped the bleeding 2 weeks after I got PVCs for over something. Well, remember now, we're talking about atrial fibrillation. PVCs is an arrhythmia, but PVC stands for premature ventricular arrhythmias. So that's the bottom of the heart, not the top of the heart where the atria are located. Have asthma. Will amio have a negative effect on my lungs? We've not had any trouble with asthma and amio in the low doses. You've emphasized the need for patience while the heart recovers. How long should one expect to allow before resuming strenuous exertion, running, splitting wood, etc.? I do a lot of runners and a lot of cyclists, people on bicycle, and they tell me by 6 months after the mini-maze, they can get their heart rate up to 150 and it comes right down. You take it easy for the first month. After a couple months, get your heart rate up to 100, 110. By 6 months, probably up to 150 and you're good. How long do I have to wait for a virtual visit after the application? Well, we're backed up right now. Kimberly lost her MA and has a new MA that's training now. Christina, who seems very good, but she's a little bit short-handed. And I think some people are waiting more than 3 weeks, maybe 4 weeks, 5 weeks. What have you heard, Sandy, before they get their virtual?
Yeah, it's a little bit longer. It's closer to 4. I get a lot of people asking me about it.
So that's, it's 5:59. We kind of breezed through that hour. Sandy, I know I didn't get all your questions. We had a lot of good response from the listeners. Some words of wisdom, either about the Facebook site or anything you want to get out there before we close.
I just want people to know that there's hope. There's hope. You don't have to live like this. And that's why I do what I do, to get that word out there.
If someone's interested and they go to Wolf Mini Maze or Live AFib Free, and they'll see that it's a private site. That's what comes up, right?
Correct.
So tell them what to do. Tell them what to do to get in the site.
You just have to type in the top of Facebook in the search bar, Wolf Mini Maze, Live AFib Free, and the site will come up, and you'll just hit join, and I will just accept you. There are 3 questions that we ask, just to kind of weed out people that, you know, aren't really there for the right reason. But all I have to do is accept you, and you're in.
And usually how long does that take, a day?
I get notifications when people, so yeah, I usually am right on it.
Okay, all right. Well, I want to thank everybody for the great questions. I want to thank Sandy for her dedication to eradicating AFib and finding some good treatments for AFib, and all the help that you give all these people that are seeking advice and hope, right? Thank you from the bottom of my heart.
Everybody, yeah, you restore the hope that everybody loses for ever having to live a normal life again.
Yeah, that's right. And as I said before, half of it's getting rid of the AFib, and the other half is getting off some of these medications that are really rough.
That's huge.
Yeah. I think we'll be, Mr. Producer, I guess we'll be up again in a month. He's shaking his head yes. On Tuesday at 5 p.m. Central Time, we'll be live again here in Houston, Texas at DeBakey CV Live. Until then, everybody try to live a comfortable life and stay out of trouble. And if you're having troubles, you can always get on the Facebook site and Sandy will sort it out for you. Thanks, everybody. Goodbye.
Bye-bye.